Well, welcome to the first lecture of this 2021 to 2022 OCD Rhode Island series. And I'm Jayme Valdez. And with me today is Mary Walters. I am a licensed mental health counselor and the founder and a clinician at Clearview OCD Counseling. And Mary works with me as a master's level clinician at Clearview. I'm also on the board of directors for OCD Rhode Island, as well as OCD Massachusetts. That's about it. I love dogs, I love sushi, I love oysters, I love risk-taking and trying new things and experimentation and helping people find ways to feel more fulfilled and satisfied in their lives. Mary, I don't know if you want to say anything about yourself and what you're passionate about.
Yeah. Oh boy, where do I start? So I am currently master's level clinician, gaining hours towards the same type of licensure as Jayme. Let's see. I love ACT. I love ERP and the creativity behind all of it. Some personal things about me. I love animals. I have a wacky assortment of them. One of them you might hear during the presentation tonight, should she decide to wake up. But yeah, that's all I have so far.
All right. Sorry. Okay. So this is going to be a foundational lecture where we're just going to go over the basics of what OCD is. We'll define it for you. We'll help you understand what different subtypes or presentations of OCD may look like. You'll also learn about what we call comorbid or co-occurring conditions or disorders, things that we often see happen alongside OCD. And then we'll review some treatment options and some resources that you can access for further learning or self-help after this lecture. So let's start with the basics. What is OCD?
There we go. So if we break OCD apart, right, we get obsessive compulsive disorder, right? So looking at the word obsessive, what we really like to use at Clearview is the word original. It's for our original intrusion. It's that unwanted mental image, body sensation, nagging feeling, anything internal that is uncontrollable and distressing to the person that is experiencing it. And then after that original intrusion comes the compulsive behavior. So a compulsion is either a mental or physical act that is repetitive and used to neutralize, prevent, reduce the impact of the intrusive thought. Right? So if the intrusive thought says X is going to happen, the compulsion is what we do to stop that from happening, regardless of whether or not it would actually happen. And then finally, disorder, that's a pretty low word. So a disorder in this sense is a chronic condition and it impacts a person across multiple domains. And what we mean by multiple domains is that it's impacting how you're performing at school, whether or not you're showing up to work and are able to complete tasks, your familial, romantic, and friendships, right? Across a wide array of things. It can also impact whether or not you like to indulge in your hobbies.
So, classic example that is often used in the media is somebody might get an original intrusion of what if my hands are contaminated? And that thought feels unwanted and distressing to them. They may have even physical sensations in their body, in their hands. They may have urges to go wash their hands or use hand sanitizer. And then they may engage in a compulsive behavior, such as washing their hands or not touching certain things, or a mental behavior, such as reassuring themselves, no, I just washed my hands 5 seconds ago. I'm sure they're clean. There's no way anything got on them. And then if this pattern starts taking over to an extent that it's impacting multiple areas of their life, then it becomes a disorder. What's less understood and publicized about OCD is that's actually not the most common kind of OCD, like being a germaphobe or a neatnik. And we'll get more into different subtypes and what is the most commonly reported subtype of OCD. But another example of how this pattern works is that somebody may get an intrusion that most humans have, like, what if I just ran my car into the guardrail? And they're driving their car and they're like, oh my gosh, like, why did I just think that? If they have OCD, they may start thinking this thought a lot and then engaging in repetitive physical behaviors and or mental acts to try to neutralize that distress that the intrusion caused, or to try to prevent a situation from happening in which they'd have to experience that distress. So they might drive really slow in the right lane. They might ask people for reassurance or start looking up statistics. They may stop driving. They also may reassure themselves up in their head, like, no, I'm a safe driver. I've never been in an accident. I'm going under the speed limit. Everything will be fine, etc. So just to lay out how this thought process works, and that for many people with OCD, it's almost a hidden disorder because most of the compulsions occur in someone's head and are private to them. And so it's not as obvious as hand washing or lining things up on their desk properly. So Mary, do you want to do this one, or do you want
Sure.
Okay.
So the DSM-5 is what we use to classify and categorize the mental health conditions that we know of to date. OC spectrum disorders used to be under the anxiety disorders category. It's now its own category in the DSM-5, which is a really good thing because the anxiety disorders are just that, right? Anxiety-based. OCD is so much more than just anxiety, right? On here, we have that, yes, it can be anxiety, but really also disgust, shame, aversion, doubt, just not right feelings or just right feelings. That's what the JNR stands for: fear, guilt, and somatic expressions, right? Somatic meaning the body. OC spectrum disorders include more than just OCD, right? It also includes body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, and excoriation, which is skin picking disorders. Currently, there's more research being done to see what other disorders could fall into the OC spectrum category in the future, those being avoidant restrictive food intake disorder, somatic symptom disorder, panic disorder, illness or health anxiety disorders, pandas, etc.
And I do just want to invite anybody who's joining us live right now. This is, we are very fluid. This can be a back and forth conversation. If you have a question, please type it into the chat box for us at any time. You don't need to wait till the end. If you have a comment, that's also welcome. And we will see that show up on the screen and take a moment to answer any questions that you may have. You can also wait till the end if you want, and we'll answer questions then too. So let's talk about who can get OCD. Anyone can, really. It doesn't specifically pick on any one type of human being, and it is observed across the globe. It has what we call a bimodal onset, which means that we often see it erupt or the symptoms become noticeable between the ages of 8 to 12 or in the late teens, early 20s. And often if we see symptoms start to develop in ages 8 to 12, we often will see them worsen in the late teens or early 20s. And one thing that I've been seeing as I've been working with this disorder for many years is that fortunately, we're seeing kids come in much younger. We're seeing some 4-year-olds on our caseloads because we are getting some awareness out there about what OCD actually is. And so instead of kids, bouncing around and, seeing a talk therapist or whatever for anxiety, it's starting to be recognized as OCD. and they are being brought in sooner for treatment. So that is one positive thing that we're seeing. In adults, there is a slightly higher incidence of women, but that could be due to women feeling more open to seeking out treatment or to other factors regarding self-reporting. At this time, the statistic is that roughly 2 to 3% of the US population has OCD. I believe that as the public becomes more educated and aware of what OCD actually is, many people who were formerly diagnosed with some kind of anxiety disorder or another mental health disorder, including psychosis, may actually realize that what they've been struggling with all along was actually OCD. And this number is probably low, in my opinion, that 2 to 3%. A very important statistic, especially for any clinicians who may be watching this at any point, is that 1 in 4 adults with OCD report self-medicating behaviors involving alcohol or substances. So 1 in 4 patients who walk through the door to receive OCD treatment are self-medicating. And this doesn't even account for what we call process disorders, which would include like addictive gambling, porn watching, sex, things like that. So because OCD can be such a private hidden hell, it makes a lot of sense that there would be a lot of self-medicating with it. And there is a lot of overlap between addiction and OCD, where somebody feels something uncomfortable or distressing internally, and then does a compulsion or uses in some way to dull down that uncomfortable internal experience. So we are passionate at Clearview about treating people who have co-occurring self-medicating behaviors, as well as OCD.
Mm-hmm. So looking at the epidemiology of OCD, one of the most common questions that we get asked is, when will I be cured? Right? And we have to look at OCD as a chronic condition, right? OCD waxes and wanes very similarly to depression. And what we mean by that is there are cycles where it's just going to be more difficult, and there are cycles where it's just going to be easier, right? For folks who experience depression, they're familiar with that, right? Sometimes it gets harder in the winter, easier in the summer. OCD operates similarly, just not according to the time of the year. Physical illness can also play a role in how OCD presents and the severity of it.
And I'll just give an example of this. I frequently will have clients who get a cold or get strep throat, and we will see their symptoms sometimes worsen while they're sick, but also right after they are getting better from the physical illness. And as another example, like I have a client who recently got shingles actually, and their OCD worsened during that time when it was on kind of an upward trajectory and getting better. And once the shingles was being treated with antivirals and stuff, then we saw the OCD symptoms come down. And at first, that client was really freaking out about, wait, I thought I was doing better. And I said, let's give the shingles, your physical illness, some time to respond to the antivirals. And sure enough, then they started feeling better in terms of their OCD as well as the shingles.
Mm-hmm. So as we talked about, OCD does present on a bimodal onset, but diagnosis after age and onset after age 35 is possible. That's just after that age marker, something where we would want to look at other medical conditions, differential diagnoses, and environmental factors about that could play into the onset of OCD as well after that age. One of the things that is unique to OCD is that it has both neurobiological and genetic underpinnings, right? OCD runs in the family. About 35, 40 years ago, right, family members might have described an aunt or an uncle or their grandparents as rigid or quirky, right? But that could have just
or even
been
having a mental breakdown and getting institutionalized.
Yep. So that's one of the questions that we're always curious to know when we get clients that come in to Clearview. It also takes folks who are searching for active mental health help about 14 to 17 years to find the right treatment. This statistic used to be about 7 years. And when we were looking at the updated data provided by the International Obsessive Compulsive Disorder Foundation, which is the IOCDF, we found that it actually takes close to 2 decades for folks to get that correct diagnosis and then to get the right help for it. Another
I
thing
would
about
say that this is something that you and I see anecdotally in our own practices, Mary, that we often see people where they're like, well, I saw a play therapist as a child and we drew pictures and played with toys, but I couldn't stop thinking about vomiting and fearing that I was going to vomit. And then they saw a talk therapist or their high school counselor and talked about their anxiety and all the thoughts in their head, but also didn't feel like they could really disclose some of the nasty thoughts that were going on. And then they got into college and saw the college counselor and just keep kind of getting bounced through different treatments that aren't really hitting the mark. And it takes quite a while for them to get in with an actual OCD specialist.
Mm-hmm. OCD also does not get better on its own, right? It's a chronic condition, yes, but with the correct treatments, which we will talk about later on in this presentation, it can get much, much better. And for those who never get treatment, data shows that the remission rates are less than 20% over 40 years. So 8 out of 10 people across their lifespan are not going to get any better if they're not getting any help.
So we got a question in the chat about why does it take so long to find the right treatment? I think that comes down to a few factors, and Mary, feel free to chime in once I'm done. I think one of the reasons it takes so long is that not only is the public not educated about what OCD actually is, which we'll get into in some later slides, but clinicians aren't educated about what OCD actually is. Most OCD specialists at this time have done the majority of their learning about OCD postgraduate school. You don't really learn much about it in undergrad or graduate school. And what you do learn there isn't very comprehensive. So that's one reason, is that even clinicians will often be well-meaning, but view it as some kind of anxiety disorder and try to treat it with relaxation techniques or looking for the evidence for or against an irrational thought, but not recognize it as actual OCD. And we are, this is why we do a lot of the work we do, is to bring awareness to what OCD actually is. In fact, Mary and I did a training for graduate and PhD counseling students at a local university, and they could not understand that OCD did not have a root in some kind of trauma. And no matter how many times Mary and I tried to explain that OCD is not caused by trauma, these graduate and PhD level students were really stuck on the idea that it was. So a lot of it comes down to education. There's also not enough clinicians who are trained and well qualified to treat OCD. So even if somebody finally figures out that what they're suffering from is OCD, maybe they've been Googling or they somehow figured it out, trying to get in with a specialist takes a long time and is also unfortunately often expensive, which is why we also provide as many free educational services as we can. Mary, I don't know if I left anything out.
I would say, a lot of therapists who practice general therapy or talk therapy are very well-meaning when they try to teach or treat OCD. But if we do look for that root cause for OCD, clients can spend years in therapy trying to find the reason that all of these symptoms started, right? Or the trauma, or try to have it go back and blame it on a parent. And that's just not the case.
So thanks for your question. Please keep them coming. We're happy to have this be a conversation.
We got another
we already
one.
have another one.
How can a patient recognize when their current therapy isn't working for their OCD?
That's a great question.
That is a great question. So do we want to save this question for when we talk about ERP and ACT, or do we want to tackle it now?
I would say a short answer is that if your therapist, like if you've been diagnosed by a mental health professional, like a psychiatrist or a therapist with OCD, and the person who's treating you is not using ERP or exposure and response prevention to treat your OCD, and has not been trained themselves, cannot tell you like where they've been trained, how much training they've done, how many hours, et cetera, then I would be wondering what kind of treatment that person's receiving. Sometimes it can take a while for OCD treatment to work. There may be a lot of co-occurring things going on. But what we'll talk about later is what the gold standard treatments are for OCD. And I guess I would say, based on my own work, if I have a patient who is not showing some kind of steady improvement, which, I use the quote, relapse is part of recovery. Like it's never a steady line, even recovering from a physical injury. It's never a steady line. There's always 2 steps forward, 1 step back, So, but if you're not kind of consistently making progress in your treatment, like if you're not better a little bit or a lot of it 4 months after you started, I would start wondering about things. And we'll get more into treatments later. Thanks for that question. Okay, so we skipped intrusions. I'm sorry.
There we go.
There we go. Well, why don't you take intrusions and I'll take compulsions?
You got it. So everyone gets intrusive thoughts. The biggest example that I love to use is the human universal of when we all go hiking, when we get to the summit of that mountain, we have 2 thoughts. 1, what if I jump? 2, what if I push the person standing next to me off of the mountain, right? Most people without OCD will be able to be like, if my buddy's real annoying, I might actually ponder that thought, or no, I wouldn't do that, right? But folks with OCD will dwell on that a little bit longer, and it'll cause more of a distressing response in their bodies and lead them to compulse, right? Intrusions could also be emotions, body sensations, or urges, right? They don't have to just be thoughts.
One thing I want to point out here is that the difference between somebody with OCD and somebody without OCD who's standing on the mountain, and they both have the same almost intrusive image, maybe an urge to jump, is that the person without OCD easily dismisses this thought. So their evaluation of the thought is, I don't feel like doing that, not relevant to me, moving on, look at the beautiful scenery. The person with OCD evaluates that thought differently and says, oh, what does that mean that I just thought that? Do I want to do that? Why would I want to do that? Am I feeling suicide? And so that's one of the differences, is that the evaluation of that internal experience, that thought, that emotion, body sensation, or urge is different. And so one thing that we try to do is train our clients to have what's called a Teflon mind, which Mary will give the classic egg example in a minute. But we're trying to have our clients understand their thoughts as just language in their heads, or just images that show up, just body sensations. That doesn't mean that they're facts or that they're predictors of what we're going to do with our behavior.
Right? That interpretation as key is very, very important, right? folks with OCD will say, well, what does this say about me? Am I dangerous? Do I really want to do this? What if I want to do this? Folks without OCD are able to, just like Jayme said, shrug it off. A lot of common themes with OCD, right, are harm and aggression. So like that.
In the interest of time, let's save this for when we get to the subtypes.
Sure.
And just to explain a Teflon mind. So if you picture a nonstick pan and you crack an egg in it, and then you were to tilt the pan, that egg would just slide off. So we're trying to get clients to have what's called a Teflon mind, where their thoughts can just kind of slide off, as opposed to cracking an egg in a pan with no oil, and it's not a Teflon pan, and that egg starts burning, you know, the thought is burning on the brain and really sticking, and you can't get it off. You're trying with the spatula and everything. So we're encouraging clients to have a Teflon mind about things, that things just kind of slide off and are not interpreted as true, super relevant, predictors of the future, etc. Compulsions, as we went over in the beginning, are repetitive behaviors or mental acts. And we really want to underscore that for many people with OCD, much of what's going on in terms of compulsive behaviors is a mental behavior, a thing that they're doing up in their head, often reassuring themselves in their head in some way, or trying to shut down and remove some kind of thought process, or shut down panic sensations, shut down an urgy feeling. So the aim of a compulsion is twofold. One is to reduce the amount of discomfort that that original intrusion caused. And then the other is to prevent a situation from happening in which somebody would have to experience discomfort. So an example of this would be if somebody got an intrusion, like they're in the kitchen and they're chopping carrots for dinner, and they're like, what if I just took this knife and started stabbing my children? They might then do a physical behavior, like put the knife down and stop chopping the carrots and just say, that's enough carrots for dinner. Or they might do a mental act, like try to reduce the amount of discomfort that that intrusion caused by saying, I would never do that. I love my children. I've put the knife down, so everything's okay. And by putting the knife down and then just going with the amount of carrots that they've chopped, even though it wasn't how much they would have chopped if they weren't responding to this intrusion, they're trying to prevent a situation like a stabbing from happening, which would then cause them further discomfort. Now, this leads to a cycle, which is what becomes OCD. And it's important to know that compulsions don't have to make logical sense. So one of our favorite cases is that we worked with a lovely young man. Mary, I don't know if you want to tell about our soccer ball guy.
Yeah, so when he came in to see us, one of his biggest intrusive thoughts that was very distressing to him was, I can't play soccer anymore because if I do, I'm going to eat the soccer ball and become the soccer ball.
Doesn't make sense. Other people might call that psychosis, but he actually had OCD and he recovered very quickly once he was in the right treatment.
So we did some fun ERP around that, played with the soccer ball, bit the soccer ball, and come to find out, nobody turned into a soccer ball.
I'm sorry, we're having like a little technical issue here. Okay. So one way, and this isn't like, you know, the only rubric for figuring out if thoughts are OCD thoughts or not, but OCD thoughts are often what we call ego dystonic. So by that, we mean that they don't feel congruent with somebody's sense of who they intrinsically are. They don't feel consistent with somebody's wishes and what they would like to do with their behavior. Something that's ego syntonic is something that feels acceptable to a person's sense of self, and their behaviors are in line with their intrinsic wishes. So the reason that OCD feels so distressing to the people experiencing it is that the intrusions are not congruent with their sense of who they are. So if they have what we call pedophile OCD, for instance, which is getting chronic intrusions about, what if I lost control and molested a child? How do I know that that won't happen? You know, how do I know that I didn't black out one night and molest a child and I just don't remember it? I'm in denial. The reason that type of OCD feels so distressing to that person is because it's dystonic. It's not in line with their sense of themselves. This person is likely somebody who loves children, who's a family man, who wants to, you know, have kids one day, loves playing with his nieces and nephews, you know, is really invested in the safety of children. So it's confusing to have these intrusions when it doesn't line up with what that person actually wants to do with their behavior or their sense of who they are.
Mm-hmm.
So we're not going to go over each of these. I think we'll just pick a couple. And this, just to be clear, is not a full list of all the different subtypes of OCD. And by subtypes, we mean there's a big umbrella, and you can picture that being OCD. And under that umbrella, there's a lot of subtypes or different themes. And people often experience multiple ones of these, especially throughout the course of their lifetime. It may start as, you know, some kind of body-focused OCD as a child, where they're worried that their heart might stop in the middle of the night, and so they have trouble sleeping. But then when they're a teenager, and the job of teenagers is to be in relationships with others, whether that's friendships or intimate relationships, then it might turn into relationship OCD and obsessing about the nature of their relationships. Like, what is love? How do I know if I'm in love? And how do I know if this is the first time I'm in love? What is cheating? Like, did I cheat just because I thought something? And then once they have a child, this could also turn into perinatal and postpartum OCD, where then they're obsessing about the baby they just had. And to be clear, that kind of OCD can happen to fathers as well. It can happen to non-gestational parents, adoptive parents. There's something about getting this defenseless little being in your care that can set off alarm bells for people who tend to be hyper primed for being aware of the potential for danger. And maybe we'll take this question and then, oops, I'm sorry. Take this question, and then maybe Mary, you could explain a little bit about harm and pedophilia OCD, or you know, one or two other things. So we have a question here. There are different subtypes of OCD, but is there an OCD intensity scale? That's a great question. There are a number of measures out there that measure the severity of someone's OCD, how much it's impacting their life, how intense or frequent the intrusions or the compulsions are. We don't have any slides here on that, because that's more scales that somebody's therapist would provide for them. But there are various scales out there to measure the intensity or frequency of OCD. I hope that answers the question. Mary, do you want to go over a couple of these and then
Sure.
plowing through?
Yeah. So, for example, right, one of the specialties on my caseload, and also Jayme's, is POCD, right? So pedophile OCD. And that's, what if I hurt a child? What if I am attracted to children? What if I'm a danger to those around me, right? Harm OCD is both towards self and towards others. What if I want to hurt my loved ones? What if my loved ones get hurt because of me? What if I hurt myself? False memory OCD is an interesting one. A really great example of this is, let's say you're driving and you think you hit someone, right? And even though you didn't feel the car jerk, you have that image in your head. So you drive back around the block just to make sure. And then you drive back around the block again just to make sure. Let's see.
Going back to harm OCD, there have been studies done on this, and it actually is the most commonly reported subtype of OCD, more commonly reported than contamination OCD, which is what people are very familiar with through the media and stuff. And with harm OCD, it can be fears of harm coming to you or to someone else, as Mary said, either through acts of violence or negligence. So it could be, somebody in a lab, for instance, who worries that if they by accident mix test results wrong, they'll harm people by giving them the wrong test results for their illness, and then the lab will get shut down and everyone at the lab will get arrested, and things like that. Or it could be worrying that you may not take good enough care of your child, and like you're not giving them enough water. But it can also be acts of violence, like picturing yourself violently harming another person or someone else violently harming you in some way. And I just want to make sure that we have enough time to get through everything. So this is just a list of some common conditions that are seen with OCD. And, we very often see some level of depression in people presenting, because it's a very distressing, private held disorder, and will cause people to feel hopeless. And we also often will see phobias, like specific phobias of certain things, as well as panic sensations in people. A lot of times also sleep disturbances, people having difficulty falling asleep, or they're waking a lot in the night, etc. All right, so Mary, why don't you get into how do we treat this fascinating disorder?
So here is our gold standard right here: exposure and response prevention, famously known as ERP, right? So the E in exposure and response prevention is letting ourselves be around the thing that we are afraid of. In vivo means in real life, right? So that might be for someone with perinatal OCD that they hold their baby. Imaginal, right, through scripts or envisioning, might be someone writing down the worst case scenario of what if they did the thing that they're afraid of, or what if the thing that they're afraid of happened to them. And then interoceptive exposures, right, are leaning into that physical experience. Can I make this feeling in my stomach more intense? Can I make it less intense? What happens if I lean in and I focus on it? Right? And then the most important part of ERP is actually the RP, right? That's the response prevention. So if I just say, okay, here's the thing you're afraid of, and I let you compulse, that's not going to help you get any better, right? What's going to help you get better is that response prevention, which is leaning into valued behaviors and different behaviors in the compulsing that we usually do, right? So my fear might be, I'm terrified to hold a child. I hold the child. If I panic and put the child down, I'm reinforcing the fact that I'm afraid of the child and that I might be dangerous. If I continue to hold and cuddle the child, maybe sniff the top of their head, like hold their little hands, I'm teaching myself, oh, I can actually handle this. And people get better really fast with ERP. In fact, it works so well that 70% of folks who go through ERP feel much better by the end of treatment, and they're no longer nearly as afraid or afraid of all of whatever that initial stimulus was, right? There are a lot of ways to conduct ERP. It used to be a hierarchy of most scary to least scary. We would start with the least scary, but now it's kind of just like an ERP menu of we're going to lay everything out and pick what we want to work on, right? And when we pick what we want to work on, we might start at an 8 on our SUDS, right, which is a subjective unit of distress, how upsetting this exposure is. And I might stay at an 8 the entire exposure, but that doesn't mean that I'm not learning and that I can't handle it. It used to be that we believed that the SUDS had to be cut in half by the end of session. So if I started at an 8, I had to end at a 4 for the exposure to be successful. But data actually shows that even if you stay at an 8 for the entire session, you're still learning and you're still teaching yourself and your body that you can handle it.
We did have another question come in, which is great. So this person would like to know, what is the likelihood of developing other types of OCD for someone who already has OCD? I believe this person is asking about different subtypes of OCD. It's really hard to say. I would say that it's hard to say what the likelihood is of that. In my experience, because this is a lifelong chronic condition that comes and goes at different times over the course of a person's lifetime, that I really don't see people that just have like one kind of OCD. They may have one subtype that is most prevalent and is most distressing to them, but when a knowledgeable clinician starts asking the right questions and knows about what all the different subtypes of OCD are, you usually unearth that there are some other subtypes going on. The other thing that happens is that we have a saying that OCD preys on someone's values. So it focuses on what's important to that person and what is most likely to bring them satisfaction and fulfillment in life. And that's why it feels distressing to the person, because I provide the example, like if I'm cooking in my kitchen with my friend Julia and I ask her to grab the lettuce out of the fridge and she grabs it and drops it on the floor, I'm like, oh, bummed, like let's cut off the bruised part of the lettuce and keep making taco salads or whatever. But if I'm cooking in my kitchen with Julia and Julia drops her newborn baby on the floor, I'm the first one across the kitchen. I'm grabbing the baby. I'm checking, if there's any wounds, I'm soothing the baby. I'm soothing Julia. My response, like my panic response, my behavior is very different, even though in both situations, Julia dropped something, but that's because I personally value children, defenseless beings. I value my relationship with Julia. Like something very important here got touched inside me. And so what we see is that over the course of a person's lifetime, their values shift and develop and get defined more. And so that's what I was talking about a little earlier in the lecture, that you may roughly have the same core values throughout your lifetime, but what was deeply important to you at the age of 4 is not likely to be the same thing that's deeply important to you at the age of 40. And since OCD latches onto the things that feel important to you, it is likely that over someone's lifetime, they're going to experience different subtypes of OCD. But that said, the good news is that it's the same treatment no matter what. And once clients learn how to do ERP, learn how to lean into the distress that the intrusion caused and then not compulse in the face of that and just tolerate the distress, then they learn how to do that no matter what the theme or subtype is. They just keep applying it no matter what shows up. But we have another trick in our pocket, and that is acceptance and commitment therapy, otherwise known as ACT. And it is called ACT because it's about action. At the end of the day, Mary and I are behavior therapists. Yes, we're cognitive behavior therapists, but we're really focused on what people do have control over, which is your behavior, what you're doing. We don't have a lot of control over our internal experiences, our thoughts, emotions, body sensations, and urges. I could try really hard right now to make myself feel a certain urge or feel a certain emotion. It's really hard to force your body to do things like that. But what's not hard is for me to force my hands to do this or my hands to do this. I can make my behavior do certain things. So ACT is a very, it's a fascinating treatment type, and it's very applicable to OCD. But it is like one of the things that it really focuses on is having acceptance of those internal experiences, which doesn't mean that you have to like them or love them or want them. No one wants to feel sad or bored or anxious. But the fact is, as human beings, we're going to experience discomfort throughout our lifetimes, whether that's hunger or loss. And so learning to allow those things to just take place without feeling like you need to always intervene and puppeteer the experience and make it do a certain thing. Like I need to make anxiety stay out and I need to make happiness come in and stay happy all the time. That's impossible. So instead we focus on what we call values-based behavior. So regardless of how you're feeling, regardless of what intrusions happen, what thoughts or emotions you're having, your behavior is always parallel to your values, what is important to you in your life. Another component of ACT is focusing on the here and now, staying in the present moment, otherwise known as mindfulness. Your mind is full of the here and now, because anxiety is really about the past or the future. It's worrying about what did happen before and will it happen again, or worrying about what might happen. If we can stay right here, right now, there's very little anxiety. ACT also encourages what we sometimes call the observer self, which is there's a part of you that doesn't have to over engage with thoughts, emotions, body sensations, and urges. There's a part of you that can take a half step outside that and just watch that experience take place. It doesn't have to do anything about it. It can just observe. There's a part of you that can do that. And if you want to get really meta about it, there's a part of you that's observing the observer. Otherwise, how else would you know that there's an observer here? And then there's an observer who observes the observer, observing the observer, you know, et cetera. And it's a house of mirrors. But we use a lot of ACT, which is like ERP, an evidence-based technique, which means that it's been scientifically studied. Mary, I'll let you swing into this one about what they have in common.
ACT is great because it not only bridges your values, but it is an exposure, right? We lean into our values to help us do the things that we ultimately want to do, right? I always pull out my Apple Pen, and my clients always know where I go with this when we talk about the spectrum of values on the pointed side and anxiety on the rounded side, right? We get to pick where we go. We can feel anxious and lean into our values, but we're still leaning into what's important. Whereas if we stay in that anxiety, we don't allow ourselves to do the things that are important to us, right? So ACT and ERP are essentially the same story, but in different languages. They both include expectancy violation. They both include experiential learning. They both have a huge emphasis on that B in CBT, right? As Jayme was saying, ultimately at the end of the day, we're behaviorists, right? ERP at the end of the day is the gold standard and should be the foundation of what you're doing in therapy. But ACT is a really lovely component that helps to give you direction outside of therapy.
And because I use so much ACT in my own work, I do sometimes have clients say, have we been doing any ERP? And we have been the whole time. I've just been using a different language for how to talk about exposure or how to talk about preventing a compulsive response and just sitting with internal experiences. But ACT is becoming very popular amongst therapists to treat a number of disorders. It's called transdiagnostic because it does treat a number of disorders and just human conditions. So it helps with boredom, but it can also treat depression. And so a lot of therapists are now becoming trained in ACT. so I would encourage anyone who's listening that if you do seek out an OCD specialist, you want to make sure that if they are using ACT, that they have in the back of their minds an ERP framework for how to present the ACT. And you do want to learn about what is their training in ERP, how long have they been using it, what's their understanding of it. And it is important to note that cognitive behavior therapy, or CBT, is not sufficient to treat OCD. So again, if we picture an umbrella, cognitive behavior therapy is the umbrella. ERP and ACT are two specific types of cognitive behavior therapy. And there are certain kinds of CBT that would not be appropriate in the treatment of OCD. Going back to that example of looking for the evidence for or against an irrational thought, imagine sitting down with our little friend who had the soccer ball intrusion, that he would pop it, ingest it, and become a soccer ball. He knew that was bonkers. And that's what was so distressing to him. It was ego dystonic. It didn't sync up with what he wanted to do with his behavior, how he viewed himself. Imagine a therapist sitting down and saying, well, let's look for the evidence for or against whether or not you're going to eat a soccer ball. That isn't going to work. He's already done that up in his head. That's called a compulsion. That's just a therapist sitting with you and compulsing. What that child needed to do is take the soccer ball and try to eat it. So that's what we did. And he saw he couldn't eat it. And then it was like, well, that's the exposure, and problem solved, kind of. So that's the behavior therapy in it. Is, all right, so you have this hypothesis in your head that you're going to jump off the cliff when you go hiking. Let's test it out. Like, let's go up there. OCD therapists generally aren't afraid of very much. And so let's test out your theory here. Like, let's go on a hike together and let's stand, on the trail and see if you jump. And when they go up there and they see that they don't jump, then they've learned something. Oh, I can walk on this trail. I can have an intrusive thought, an intrusive image of jumping. I can even feel an urge to jump. And my behavior is to not jump, because my behavior is in line with my values of staying alive and getting back home to my family and enjoying the rest of this walk. We do have another question here. Give me 1 second. So this person says, this is probably a question for the end, but I wanted to make sure I asked, what is the best way to support someone with OCD? We will get to some resources at the end. This isn't on the slide, but it's a great question. And, if the person asking is somebody who is the loved one of someone with OCD, I just want to thank you for being there in their life and for attending the lecture and for, trying to find out how to best support. We are going to have a lecture later in this series on reducing family accommodation of OCD. So how to, instead of providing reassurance, for instance, how to do other things instead, such as empathize, and then ask the person to use the skills they're learning in treatment. But there is a great book out there by Jon Hirschfield, called When a Family Member Has OCD. And it has a lot of information about things to do, things not to do. So I would look at those two resources, Jon Hirschfield's book, When a Family Member Has OCD, as well as an upcoming lecture through OCD Rhode Island on reducing family accommodation of OCD. And we'll have some more stuff here. So just quickly, we'll cover this quickly. How does exposure therapy work? We used to think that it only worked through habituation, that if the person stayed with the stimulus long enough, then they would adjust to it and habituate to it. So a metaphor we use is, if I jump into a cold lake, it feels like 1,000 knives at first. But if I stay in the lake for a little while, it starts to feel comfortable. And then Mary's on the boat and she's like, how's the water, Jayme? And I'm like, it's great. And so Mary jumps in and she's like, what the heck, Jayme? Like, it's freezing. The lake didn't change temperature. I just stayed in the lake long enough that my body adjusted to the temperature of the lake. Mary will need to habituate to the lake's temperature. So that's habituation. But another way that exposure therapy works is that it violates someone's expectations. This goes back to the idea that somebody has a theory or a hypothesis. They have beliefs about what is going to happen or how bad it will happen, or that they won't be able to tolerate it or survive it. So that's when we run what we call it Clearview behavioral experiments, which are really just exposures. Let's test it out. How does that work? Like, maybe it does suck, but like, did you learn anything from it? Did you survive it? And this can lead to feelings of self-efficacy, increased confidence. You feel confident. Maybe it's not fun to do something. I'll give an example, childbirth. But I'm able to do it, and I feel proud that I was able to do that. And I have a beautiful child now because of it. So it wasn't pleasant. Don't want to do it all the time, but I can do it. And then exposure therapy also gives us opportunities for new learning. If we just avoid, we don't ever learn anything new. We just learn that I stay safe and I stay semi-comfortable because I'm not engaging in this thing. But if we engage in the thing that we're avoiding, we learn maybe it wasn't as bad as I thought it would be, or I was able to handle it, or it turned out completely different than I've been envisioning it would, etc. So these are some of the ways that it's like the mechanism of change for when we do exposure. This is why it helps people overcome their OCD. Just give me 1 second here. Just waiting for the slide. These are just some commonly prescribed medications. Mary and I are not medication prescribers, so we can't talk a whole lot about this piece, but just to know that SSRIs and SNRIs are commonly prescribed to treat OCD. And some things to know about that is that many people with OCD have fears about taking a medication. That's very, very common to have a patient who doesn't want to take an antidepressant, which is what an SSRI or SNRI is colloquially called. But it's also possible that medication may not be necessary, that the behavior therapy, the ERP and/or ACT may be sufficient. But if somebody does take an SSRI or SNRI or another medication to treat their OCD, it is important for clients to expect that often they'll need a higher dose than what might be used to treat generalized anxiety disorder or depression. OCD often demands a higher dose of the same medication and often takes a longer period of time before the symptoms start to remit. So what we often see is that people come in and have done a lot of medication hopping because they were taking medications, but at too low a dose or not for long enough time. And so they thought it wasn't working, but really it was just kind of like taking a baby aspirin to treat a migraine. You know, right medication, wrong dose. So it's important for people with OCD to know those factors when considering medication. You do also want your provider to rule out other disorders such as bipolar disorders, because that could complicate how medication is prescribed to a person. Mary, I'll let you do this one. We've already done the hiking metaphor, so.
Yeah, I think it's just good to have those statistics up on the screen that 94% of people in general, have intrusive thoughts. Intrusive thoughts are not proprietary to OCD. OCD is not the only mental health condition that includes intrusive thoughts. Additionally, 40% of people without OCD report some level of suicidal ideation. That's also not proprietary to OCD. So the biggest thing that I want everyone to take away from these statistics is that you are not alone. You might have a mental health condition that somebody else around you doesn't have, but you are not alone in having intrusive thoughts or even in feeling occasionally suicidal.
And this again goes back to the idea of how we evaluate these intrusions that happen. So if 94% of people on Earth report having intrusive thoughts, and I think it's really 100%, and that 6% are lying or they didn't understand the question. But if let's go with 94% of people report at some point in their lifetime having an intrusive thought, the difference is that they were like, well, that was weird. That was like a super weird thought or image I just had. Anyway, moving on. So this also goes back to a little bit to that question we got about how to support someone you love with OCD. These are some common resources. The first is the International OCD Foundation. And if you go to that website, you can click the Find Help tab and enter your zip code or your city, and it'll bring up a list of providers as well as possibly support groups or lecture series that are local to you. And although the IOCDF can't, vet these people, generally, if somebody is listed on this website, they've probably had some level of training in providing ERP. There is also an article on that website about what questions to ask a therapist to know if they're qualified to treat OCD or not. You also are probably already aware of OCD Rhode Island. We also have the affiliate OCD Massachusetts, and both provide free lecture series throughout the year. We take the summers off, but otherwise it's once a month. And also support groups. Previously, we would hold these in person in Worcester, Northampton, Belmont, and Providence. Hopefully, post-pandemic, we'll be able to go back to in-person lectures as well as support groups. For now, they're virtual and posted on the OCD Rhode Island and OCD Massachusetts YouTube channels, as well as for OCD Rhode Island, it's posted on our website where you can watch past lectures. And then a place that is very commonly used by many of our clients is McLean Hospital, which has the OCD Institute, as well as one for children called the OCDI Junior. And those are more intensive treatment programs for OCD, extremely effective. They have fabulous staff, love working with them. For anyone who is thinking of becoming pregnant, then we often will recommend touching base with the Fish Center for Women or MCPAP for Moms in terms of finding out specific things, in terms of medication or something like that for handling OCD. And we have a question here. Thank you so much. This was very insightful. Have to hop off. Well, that's sweet. Thank you very much for coming. You can look up any of these. OCD Game Changers is another organization trying to help OCD. Two podcasts that can be helpful are the OCD Stories podcast, as well as Your Anxiety Toolkit. And then we have just a few more programs and centers listed here. So we're over time. Feel free to contact me, Jayme Valdez, at this email address, or Mary at that email address, or visit our website. We have a lot of free information up about OCD, as well as blog posts and podcast things that you can listen to. And that website's ocd-therapy.com. And thank you very much for attending the lecture. If anyone has any last questions, you can throw them in the chat, but otherwise we're going to sign off. And we do. We have a thank you. Well, thank you. Thank you very much for coming. It was nice to get everybody's questions. All right, so we're going to wrap it up for the night, and hopefully something in here was helpful to someone. Mary, thank you so much for joining me, and I love I love working with you, and you're such a great addition to the OCD treatment community. And we had someone else say, thank you for the book recommendations, which you are welcome. All right, take care, everyone. Have a good night. And there'll be another lecture for free next month.
Bye, everyone.